Hi everyone, my name is Alexandra. I'm one of the pharmacists at the Calvary Adelaide Hospital, and today we have a webinar on oral corticosteroids in asthma. So corticosteroids are used for many different indications because they have proven benefits and because they are low cost. Oral corticosteroids are sometimes used in the management of asthma and flare-ups in asthma for their potent anti-inflammatory effects. In asthmatic airways, corticosteroids inhibit the production of pro-inflammatory mediators and reduce the migration of inflammatory cells to the lungs. So this accelerates the symptom relief in acute asthma and prevents the relapses. Corticosteroids can be said to have mainly glucocorticoid or mainly mineral corticoid or a combination of the two. Glucocorticoid effects predominantly referring to the anti-inflammatory responses, but mineral corticoid effects is mainly relating to sodium retaining effects. So for the management of asthma, we prefer agents with glucocorticoid effects, whereas agents with minimal mineral corticoid effects are preferred. The most commonly used corticosteroids in asthma management are prednisolone and prednisone. Prednisolone and prednisone have equivalent efficacy as oral corticosteroids, and as parenteral agents, they are just as effective in an oral form as a parenteral form. So why not use oral if it's going to be just as good? And it also prevents the need for the patient to have a little injection of the agent, which is going to be more comfortable for them as well. Prednisolone is a preferred drug, especially because it's already metabolized. So patients with liver impairment, we prefer to use the prednisolone, because if we use prednisone, it might not be metabolized well by the liver, and then it may not be as effective. We do have another option, which is to use dexamethasone. Dexamethasone has a longer half-life. However, we can use shorter courses, and so sometimes that might be preferred in some patients. So for the indication of use, the therapeutic guidelines recommends oral corticosteroids in all cases of acute asthma in patients aged more than 6 years. The exception being mild cases that respond quickly to bronchodilators and that are resolved completely by bronchodilator use. The second indication would be all cases of severe asthma with a wheeze in children who are aged 1 to 5 years. For adults, the recommended dosing would be 37.5 to 50 milligrams daily for 5 to 10 days. And the dexamethasone there, as you can see, a fairly short course, 2 days of only 16 milligrams daily. When we look at the asthma handbook, there are a few trials which assess the efficacy of oral corticosteroids to manage the flare-ups in children under 5, but very little evidence regarding the use in young children outside the hospital environment. So I guess we would only see this really as a pediatric ward in the hospital. When we use the steroids for acute asthma, we generally don't see a tapering dose because it's a very short course. We have had a lot of experience using corticosteroids in asthma, and we have found over time that studies show in the emergency department, if we use these agents very quickly, we're going to get a very rapid response. And so we can decrease the need for the patient to admit to the hospital. If we're using them within an hour of presentation of the patient to the emergency department, we can reduce the risk of hospitalisation by 60%. So that's actually very beneficial for our healthcare system in hospitals, especially with the hospitals being so busy. When we use any medication, we know that it comes with side effects. So side effects coming from steroid use are listed on the slide. I think we should take into consideration that a lot of these patients may have comorbidities, and so we need to consider what side effect will be most important for what patient. Some of the side effects we can reduce by simple things like nausea and vomiting side effect. We can reduce by giving with food. Insomnia, we could give earlier in the day. We know that steroids do keep us awake. So if we give it earlier in the day, hopefully the patient will still be able to sleep at night. For patients with other comorbidities such as cardiac, we need to watch out for the blood pressure and if they're retaining fluid. And then for diabetic patients, obviously we watch out for their sugar levels because we know steroids can increase the sugar. That's more short-term side effects, but when we're talking about long-term use, which hopefully we don't see in acute exacerbations of asthma, we would think more about immunosuppression from the steroids, so increasing the infection risk, hypertension, again in that cardiac patient, deranged lipids, what effect is it going to have on the diabetic patient with the increased sugar levels over time, and then patients feeling hungrier when they're on the steroids, so maybe eating more and redistributing the body fat, fatty liver, long-term side effects, which are caused by long-term use. What we know about steroids is that we do have accumulative exposure over our lives. So that means every time we take the steroids, it adds up. And over time, we don't want to have more than our basically accumulative exposure to these medications, because then that leads to an increased side effects. So for prednisolone, we're looking at about 2.5 grams maximum over our lifetime. Some cases, it can be even as low as 500 milligrams. So we're looking for using asthma specifically as an example. If we're giving people steroids every time they have a flare, we need to watch out for how many times they're having the flare as to how much steroid that we give them, because as you can appreciate, it might not be that hard to reach to 500 milligrams of prednisolone before we start seeing some risky side effects in these patients. How can we manage the adverse effects? So we can manage the adverse effects by giving the steroids only for a short duration. We know that short courses of this medication are associated with a lower risk of adverse effects than the long courses, and even the long courses of the low doses are associated with a more risk of side effect than short courses of high ones. People may underestimate the risks of the short-term use. So we really need to take into consideration how many times we're giving these patients steroids to treat the asthma flare-up. There are some specific side effects which we see in short-term use of these drugs over accumulation of courses, and we know that we can increase the risk of sepsis from infection, VTE, and increase the risk of fracture because we are decreasing their bone density. So it's really important that we maintain vigilency over the use of these drugs in asthma flare-ups. There have been lots of studies that have been published which explain this and which make sure that we are really paying attention to how often we are using these and how long we are giving the patient this medication for. there is a consensus on the use of oral corticosteroids in asthma, and this was introduced because the clinicians had a concern that they were being used quite erratically, and it was putting the patients at risk of serious side effects and irreversible harm. So the Thoracic Society of Australia and New Zealand used data from the United Kingdom to show that high rates of oral corticosteroid use in patients with difficult to control asthma led to inappropriately high use of these drugs due to patients just using them for mild asthma. And so they instead said that we need to look at the control of asthma and why is the patient always having to use corticosteroids for flare-ups. What's going on in the background that these patients keep on having to use their steroids. So the strategies that they came up with was that we should focus on improving asthma control and preventing exacerbations, because we all know that prevention is better than cure. So what can we do to improve their asthma control? We can improve their inhaler technique. So make sure that they know how that they're using their inhalers. We can make sure that they are using their inhalers, so adherence to the therapy. We can make sure that the patient is educated about their condition. Smoking cessation is a really big one. Obviously, it's going to improve their lung function if they stop smoking, which is going to help with their asthma. We need to make sure that there's a lot of different healthcare providers on board with this so that the patient has got access to different resources and knows where to go when they need help, and optimize all their medications. So therapeutic guidelines suggests that there's about 90% of patients with incorrect inhaler technique. That's a lot. When you're thinking about those patients that you're seeing every single day, maybe coming in to get prescriptions, or that you're seeing in the hospital who've come in with existing puffers, if you think about 90% of them aren't using them correctly, then we need to think about what can we do to help these patients to use them correctly so that they're getting the maximum benefit for these puffers. There are lots of resources they can access to help them show them how to use correctly. They can download things from the Asthma Council. You can download things for them, pictures on instructions. Sometimes are better than just word instructions, so that they are getting to know how to use their inhalers properly. Obviously, we can improve the inhalers, how they work, by using things like spacers or masks with kids, but just educating them on how to improve their technique will hopefully help them to get a better control of their asthma symptoms. There are a lot of different things which can influence patients' adherence to medication. With puffers, it could be something just as simple as it doesn't fit into their daily routine, or perhaps they're using it and then they found that their symptoms are improving, and so then they think they don't need to use it as much anymore. So even though it says twice a day from the doctor, they might only be using it once a day, and then they're starting to see a bit of exacerbation happening. They need more steroids. So we need to go back now to making sure that they're using their medication and adhering to it correctly. We know that patients adhere more correctly to a simpler dose regimen rather than a complicated one. So some studies have found that medications which are about 4 times a day will only achieve about an 18% adherence rate, rather than when you compare it to a twice a day, which can be about a 70% adherence rate. So we're looking at how we're going to make it simpler for the patient so that they actually do use it. Asthma education is really important, because if the patient understands why they need to use the medications and how it's going to help them, then they're more likely to do it. When they need to use their medication is really important. They need to understand the difference between the preventer and the reliever. They need to monitor how they're feeling, monitor their symptoms, make sure that they are using their relievers when they need to, not leaving it until it's kind of a bit too far gone, and then the reliever's not helping them, and then they would need to use the steroids instead. They need to know how soon should they seek medical advice, how soon should they talk to the asthma nurse or to the respiratory physician or even the GP or the pharmacist. Like, how quickly do they need to see that the healthcare professional to help them get a relief of their acute exacerbation. And also what to look out for in terms of what might cause them an acute relapse in their asthma. So sometimes that could be allergens in the air, dusts or pollens, could be seasonal. They could be coming off of a respiratory infection or just starting on a respiratory infection, and that could obviously impact their lung function. They could have chemical irritants in the air, strong odors, even perfumes, smoke. Their asthma quite commonly can be made worse by physical exertion. So sports, exercise, making sure that the patient has their reliever puffer with them when they're exercising is really important, especially if they do have exertional asthma. And certain medications that might make their asthma worse, such as beta blockers or anti-inflammatories. The idea of having a multidisciplinary review of asthma can include things like an asthma action plan. If a patient knows what to do, if they start feeling unwell, then they can act quicker. And if they do that with their action plan, they have specific instructions what to do when. So if they're feeling fine, they know that they just have to use their regular puffers. If they're not feeling so great, but they're not too bad, they have a clear set of instructions what to do at that point, and hopefully get back to the stage of they're feeling well quite quickly. If we let it go and then the symptoms get a lot worse, it's harder to get back to that point of feeling fine, 100%, nothing, nothing going on with their relapses and exacerbations. So we want to empower them so that they know when to act and what to do to get back to feeling 100% better. If they are able to do that, then they decrease the amount of time they need off from work or miss school in terms of children. We also decrease the hospital admission, because if we can get them back to feeling better before their symptoms get worse, then they reduce the need for coming into hospital, because they're not actually going to keep having that exacerbation and get worse and worse and worse to the point where they can't treat themselves at home with their relievers anymore. We know that the asthma plan also decreases the emergency visit to the hospital and to the general practice. The asthma action plan also helps them to decrease the need for the reliever medication, because it explains to them specifically how to use their preventer and why it's really important to maintain the preventer use. And over time, it will improve their lung function, because if they're using their preventer or their other medication that's preventing them from having a flare, then the lungs maintain obviously a better function, and over time we're reducing the exacerbations, which means that over time the lungs are healthier. Smoking, we mentioned, is one of the biggest things that these patients can do to reduce their exacerbations in asthma. And we know that tobacco smoke causes asthma exacerbations. So if we stop these patients from smoking, if we help them to stop smoking, then these patients hopefully will notice a lot less exacerbations and better lung function over time. We as pharmacists can help these patients by recommending nicotine replacement therapy as a first-line option. There are different forms such as gum, inhalers, patches. Some patients might be able to access this through the PBS. They can speak to their doctors about that to help save a little bit of money, because otherwise these things can be expensive. And also free counselling services are really important for these patients, because we want them to have the best chance of success. So Quitline or any of the asthma foundations, someone to talk to on the phone might be really helpful for these patients, and to help them to maintain the will to quit, because obviously any habit can be hard to get out of once you're addicted to that habit. We mentioned that it's important for a lot of different healthcare providers to be involved in the management of asthma, because everyone comes with their different experiences and can help the patient in a different way. We also need to identify if these patients have comorbidities and make sure that they're managed well as well. So that may mean different referrals to different specialists. Some patients who have other comorbidities might be using oral corticosteroids for other uses. So we need to take that into account when we are using corticosteroids for asthma exacerbations. So we can start looking at specialist referral for the patients with different comorbidities, especially if they need to have oral corticosteroids quite frequently. Specialists may be able to identify the patients which would benefit from biological therapies. Biological therapies are quite new for asthma. A few of them are listed on this slide. They are all available on the PBS for the treatment of uncontrolled severe asthma. So obviously the patient will need to have tried other therapies first before they can access these through the PBS. They are also only effective in special phenotypes. So patient phenotyping will be required before the drug can be given to the patient. These medications have been shown to reduce the need for oral steroids in about 50% of cases. About 14% of cases in the trial was shown to actually negate the need for oral steroids. So yeah, that's, I guess, really good in those patients to cease the need, to use those oral corticosteroids. That's ideal long term. Of everything that we talked about, we don't want these patients to keep using the oral steroids. So there's one of the medications, that was the mepolizumab, the benralizumab medication, maintenance oral steroid dose was reduced by 75% in the patients using these ones. So we can see this trend that these biologicals are reducing the steroid use, and this is what we want to see long term in these severe uncontrolled asthmatics. Dupilumab was associated with a 59% reduction in exacerbations. So again, we're noticing that these are definitely working. For the omalizumab, we have a 61% reduction in the exacerbations of asthma patients compared to the current asthma therapy. So obviously all the trials are saying that these medications are reducing the exacerbations, reducing the steroid use. So for those uncontrolled asthmatics under specialist advice, they are really helping them. There there is a little bit of evidence for long-term antibiotic use, but we don't like to use antibiotics long-term. Obviously, we all know that long-term antibiotic use leads to resistance to antimicrobials, which means that we can't use them for the indications that they're actually meant for. And they're not PBS approved for this use either. So this is a really off-label use that the specialists would do as a last option. I think we are all quite aware about AMS in our hospitals, and so we need to be quite vigilant about the use of antibiotics in these patients, especially if they become immunosuppressed from their long-term steroid use as well. Lastly, we're going to talk about optimizing our medication use. So we have talked a lot about using our oral inhalers correctly. We need to make sure that we are ensuring that they're prescribed at the correct doses, that the patient is not overusing them or underusing them, and that they know when to use them. So for the inhaled corticosteroids, the dose needs to be appropriate for the patient. Add-on therapies such as the LABAs and the LAMAs can be considered as appropriate, but those oral inhaled corticosteroids are really the cornerstone of the maintenance therapy. So making sure that the patient is using them correctly, and then we know that if that's being done, the need for the oral steroids reduces. So to summarize, while the oral corticosteroids are just as effective anti-inflammatories in the management of asthma, they are associated with a wide range of adverse effects. So if we overuse these, or if we use these incorrectly and flippantly, the medications can cause irreversible harm. We don't want that in these patients. We want to reduce the steroid use. We know how to do this. This is with good asthma management. This is with making sure that the patient is educated about their condition. The patient knows to use their inhaler, their preventative inhaler appropriately. Their technique is good. They're using their reliever when they need to. The exacerbations, reduce the need for oral steroids, and reduce the risk of the side effects. So thank you very much for listening today, and we'll see you